Good evening, everyone. My name is Ryoji Tokashiki of Shinjuku Sports Clinic, Tokyo, Japan. It is my great pleasure to make a presentation about my research. Today's topic is botulinum toxin injection using a carbon needle via laser approach. The EMG guided method is very common all over the world, but it is technically just a little difficult. And when you want to confirm the location of the needle, so you ask patient to phonate or breath, holding patient's breath. And however, the needle chip may shift when the patient swallow or phonate. When phonation, the patient larynx sometimes goes up. And when botox is injected into the LCA, hoarseness and aspiration are more likely to occur. There are some methods of awakening of a specific vocal cord injection, pulmonary and percutaneous approach. And there are three options of percutaneous approach: transcyrohyoid cartridge approach, transglycoside approach, and transcyrohyoid approach. And cyrohyoid approach is better than other procedure because it enables surgeon can see needle chip by endoscope. Amin first reported this method in 2006. However, he also reported it is difficult to reach anterior part of the vocal cord. In 2012, Aka reported the procedure using double bent needle. He says it is easy access to anterior part of the vocal cord. However, sometimes it is difficult to reach the vocal cord in big larynx because the needle is short. Our cyrohyoid approach using double bent needle is like that. We use a long needle of 6 centimeters and like that, bend the needle at the two position and it insert the needle above the Adam's apple. I will show preparation and technique. Two separate 45-degree bends are created at about 1 and 2 centimeters from the needle chip, like that, here and here. And total angle is 19 degrees. And the disposable 2.5 milliliter syringe is useful as a needle holder, like that and like that. And please see the video. Make one bend and make second bend. Yeah. In former slide, I mentioned 2.5 syringe is useful as a needle holder, but for botox injections, a 1 milliliter syringe must be used. When 50 units of botox is dissolved in 2 milliliter of saline, 1 milliliter equals to 2.5 units, and when dissolved in 4 milliliter saline, 1 milliliter equals 1.25 units. And before the procedure, the topical anesthesia is needed. 4% lidocaine nebulization, 3 to 5 minutes. For the patient who have severe gag reflex, 5 minutes nebulization will be needed. While in some patients, especially the elderly patients, nebulized anesthesia alone. Only alone this procedure is sufficient. However, most patients need additional topical anesthesia. 4% lidocaine is spread through the instrumental channel of endoscope. This endoscope is diameter is 4 millimeter, and this is the instrument channel, and sprinkle the lidocaine using a syringe through the instrumental channel here, and this is endoscopic view. Breathe as patient phonate E and sprinkle lidocaine like that. And in case of patients who have severe gag reflex, 4 or 5 times lidocaine spray will be needed. And there is a caution, it is very important. In severe asthma patients, lidocaine enters the tracheal branches and triggers an asthma attack. So you have to avoid, or you should avoid, to use this procedure or to use this anesthesia, lidocaine spray, for patients who have severe asthma. And to confirm whether the anesthesia is working or not, please insert the endoscope below the vocal fold, like this video. When patients have no gag reflex, anesthesia is working. And the thyroid notch is marked. And in some patients, the anterior jugular vein is visible via endoscope light, like that. And be careful to avoid the anterior jugular vein to prevent hematoma. But if hematoma occurs, it is not a big problem. And it is very important to tilt patient head back and lift the chin. And we sometimes ask patients to lift their necks forward to show their arms upward to the person or to the friend in front of them. This order is very effective. And this is the confirmation of the insertion point by pushing the thyroid membrane. Sometimes you may insert the needle through cricothyroid membrane or above the hyoid bone. And please confirm the insertion point like this video, like that. Push here, and if you push the thyroid membrane correctly, you can see like this. And the needle is inserted just above the thyroid notch by watching the vocal cord through endoscopy. I always performed only by myself, holding the endoscope in left hand and insert the needle by right hand. But of course it is okay performing this procedure by 2 doctors. It is the insertion. And the needle should appear below the epiglottis petiole here, And if needle appears above the petiole, it sometimes cannot reach the vocal fold because insertion point is just a little higher. However, for the patient whose size of the larynx is very small, the needle can reach the vocal fold even if the needle appears above the petiole. It depends on the size of the patient's larynx. And however, in such cases, if the needle cannot reach the vocal fold, needle may be inserted above the hyoid bone sometimes, so please retry. You can see the flexible movement of the needle. A deep complete insertion to the second bend. One bend and it is second bend, and this procedure enables the needle to reach not only the vocal fold but the vocal process and posterior part. In other words, you can reach the needle every part of the vocal fold. Anterior commissure, vocal process, and anterior part of the vocal fold. And botox injection for spasmodic dysphonia. Botox should be injected into the TA muscle, and you can confirm and you can see correct insertion of the botox into the TA muscle. One of the great advantages of this procedure is you can inject materials both sides, only one insertion. Because the endoscopic view is two-dimensional, sometimes you may get the needle too deep. And you can check the depth of the needle chip by moving it inward like that. Sometimes the depth of the needle chip is deeper than you think. And if the needle goes too far laterally or posteriorly, botox may be injected into the LCA muscle. Here, to posteriorly and to laterally. However, there are no major problems, but swallowing difficulty and hoarseness may become worse. This is the voice change before and after botox injection.
おはようございます。
おはようございます。
おかい。
おはようございます。
いらっしゃいませ。
いらっしゃいませ。
やぶの中から。
やぶの中から。
うさぎがぴょこんと出てきました。
うさぎがぴょこんと出てきました。
Patient voice is very stronger and tightened.
おはようございます。
おはようございます。
いらっしゃいませ。
いらっしゃいませ。
やぶの中から。
やぶの中から。
うさぎがぴょこんと出てきました。
うさぎがぴょこんと出てきました。
続けていってね。
Patients can speak very fluently without strangulation after injection. This is the complications. No severe complications we experienced. And it is the data of the COVID pandemic. And just a little bleeding, small hematoma of anterior jugular vein, maybe 11 cases, and bleeding on the surface of the epiglottis. It is the insertion point. But every bleeding stopped within minutes in all cases, and the failure rate is less than 1%. One is uncontrollable gag reflex, and sometimes, no matter how many times you try, you cannot see the needle, and the needle won't come in. In such cases, the insertion angle of the needle may be too downward, like that, and please change the insertion angle and try again. And there is another option which is more easier than my procedure. It is injection using a needle for esophageal varices. Insert the needle through the instrument channel of endoscope. Okay, please see the video. It is very easy. Botox injected completely. And our needle surgery is used for not only for injection but for incision in the vocal fold region. I will show just a little of them. First case is kappa injection for unilateral vocal fold paralysis. This is very severe UVFE after aortic surgery. Whose MPT is only 1 second. And Kaha is injected outside of the vocal process, like that. And big advantage of this procedure is you can check the patient voice, because patient is awake and sitting on the chair, and you can also check the vibration of the vocal fold by stroboscopy. It is 1 month after injection. Patient's voice drastically improved, almost normal. Second case is vocal fold chest. Our method is wide opening method, also performed under topical anesthesia. Patient is also awake and sitting on the chair. This picture is the schema of our procedure. Make an incision on the vocal chest and remove the inside part of the vocal fold chest with the vocal fold membrane. This is the procedure. And insert the one side part of the forceps into the cutting edge and remove the vocal fold chest wall. It is 1 month after surgery. Vibration is very good. And voice is very good. Okay, if you are interested in my procedure and if you need detailed information, please read my English papers. This is for double vent surgery, and this is vocal fold chest surgery. This is the end of my presentation. Thank you very much for your time. Thank you.